Next up is Dr. Mark Erlander, Chief Executive of Cardiff Oncology. Mark is a scientist turned CEO with a deep background in cancer biology and a mission to outsmart cancer resistance. And that mission is showing real promise. Under his leadership, Cardiff has focused on a major unmet need in oncology, which is first-line RAS-mutated metastatic colorectal cancer, an area where treatment options haven't changed meaningfully for a really long time. Their lead drug, Onvansertib, is a first-in-class oral PLK1 inhibitor that's currently being evaluated in a randomized phase 2 trial. The drug is being tested in combination with standard of care chemotherapy plus bevacizumab. Now here's where things get very exciting. In February of this year, Cardiff showed early data from the first 30 patients in their trial. The 30 milligram Onvansertib dose showed a 64% response rate, nearly double the 33% seen in the control arm, with deep tumor shrinkage and strong tolerability. We're now approaching key clinical update in the first half of this year, which will include more mature response data that clearly can show progression-free survival trends and confirmation of the optimal dose. The update should set the tone for a move into a registrational trial and potential discussions with the FDA for a path forward. So with that, I welcome Dr. Mark Erlander.
Thank you very much. Thank you, Eric, for that introduction. I have 30 minutes, and does somebody have a timer so they keep track of this? Because we're kind of like not on the half hour here. So I'm Mark Erlander. I'm the CEO here at Cardiff Oncology, based in San Diego. And it's my pleasure to tell you a little bit about Onvansertib and where we are in this journey. So Onvansertib, as Eric mentioned, is a small molecule. It's very well tolerated. It's an oral drug that inhibits a very specific enzyme called PLK1, which is a serine threonine kinase. And at a high level, PLK1 is an enzyme that is hijacked by tumor cells. It's overexpressed by tumor cells, and it allows tumors to have this uncontrollable growth and metastasis. The specificity, you can show you here on the right-hand side, you can see that it's very highly specific for just PLK1. There are other PLKs in the human genome, but you can see here that there's about a 5,000-fold greater specificity for PLK1 versus the others. So really, this is really, the next two slides are really telling you about our journey. And let me just make sure that this can kind of work. Is this that's it here, yeah. And really, it started with in second line. We were in second line RAS-mutated colorectal cancer, and we had an unexpected finding, an interesting finding, quite frankly, an exciting finding, that we had patients who had a very high response rate, a subset of those patients. And it was really that propelled us to do a lot more preclinical research and be able to identify why we were seeing these really incredible responses in second line. That then, in essence, moved us into going to the FDA with the data, and we announced a shift from second line to first line, and this was really where we actually moved into first line, supported by the FDA. And then in December 10th of last year, we then put out our first set of data, which was on the first 30 patients in a randomized first line trial. Now, what I'm going to do here today is start actually at really what happened just in the last couple of months, and then I'll go back and talk to you more about the genesis of this whole program. So really, it was our shift from the second line to first line, and metastatic colorectal cancer in general is on the left-hand side is the fourth most commonly diagnosed cancer in the United States. But as you can see on the right side, it's also the number 2 killer in the United States. And when you look at the first-line standard of care, what's out there today for RAS-mutated patients who have RAS-mutated tumors, which is about half the population, Really, the last drug approved was Avastin, and that was over 20 years ago. So it's really a huge unmet need. As we sit here today, it's chemo plus Avastin or Bev. And if you look at the landscape, recently approval of a G12C inhibitor in second line, the Amgen drug. You can see here, though, it's a very small sliver of the patients who have RAS mutated tumors. It really makes up only about 4% of the colorectal cancer. So, and what we're going after is all of the patients that have a RAS mutation. So you can see here that it's over 50% of patients have some sort of RAS mutation in their tumor. So what was the trial that we did? We started this trial last year, and this is on the going from left to right on this slide. It was really a first-line trial with RAS mutated, unresectable, and patients who had not received Bev before. In the middle of the slide, you can see that there were 6 arms to this trial, which could be put into 3 major buckets: standard of care, which is 2 different types of standard of care are approved for in colorectal cancer. That's either the FOLFOX, the oxaliplatinum, or the FOLFIRI, the irinotecan-based chemos, plus Bev, and then on top of that, then we added either 20 or 30 milligrams of Onvansertib. On the bottom, you can see that the primary endpoint was response rate, ORR, objective response rate, and all of the data I'm going to show you came from blinded independent central review, which is called BICR for short. On the right side, you can see the actual dosing schedule. What you see there is that Onvansertib, which is oral, the patients take that 5 days and then 9 days off, and that is overlaid on a 2-week schedule of standard of care of infusions of the chemo plus the Bev. The objective of this trial was really to really demonstrate the efficacy of Onvansertib in combination with chemo versus chemo alone or standard of care alone, and also to examine 2 different doses. This trial was a result of the meeting with the FDA. This is really what we call Project Optimus. Some of you are probably quite familiar with this. This is really the attempt to identify a dose that's the lowest dose that has the greatest amount of efficacy. And so this is Project Optimus that the FDA looks for all sponsors to do to get the best dose. And you can see here the other thing to look at, what we're looking at, of course, was safety. Now, the trial is really the first look was 30 patients out of the 90, so it was an early look. And what I'm just showing you here is that the maturity of the data across the arms such that we were able to compare the patients in the different arms. This is the top-line data that we saw. This is a standard waterfall plot. Going down means tumor shrinkage. If you reach the threshold of a 30% or greater tumor shrinkage, the color of the bar turns to a teal, which is really considered officially a response. You can see here that overall the experimental arms had a greater response rate than the control. And then there was 2 ways that we parsed this data. One way was to look at the different chemo backbones, and the other was to look at the different doses. So we first looked at in essence, the control arm, or where you're looking at here by itself, the FOLFIRI and the FOLFOX, and then also looking at the experimental arms of adding Onvansertib on top of either of the chemos. What we can see here is that in both cases, adding Onvansertib increased the response rate in these patients beyond the standard of care chemo and Bev. Also, we looked at the different dose, and we're seeing here is that on the left was the control arm, and then what we saw here was that the standard of care plus 20 mg and standard of care versus 30 mg. And you can see that as we increase in our dose, we also increase in the response rate. A way to look at that a little bit better is called a spider plot. Spider plot really, in essence, is each one of these lines is a patient. And the patient, this is really looking at the tumor shrinkage. And so if it's going down, the tumor is shrinking. You can see right away that the higher dose, we had some patients, that the patients much greater, deeper responses. In fact, one tumor disappeared altogether, so that 100% reduction of the tumor. So this really was exciting for us to see this, and this was really very encouraging as an initial look of this trial. You can also look at it through a swimmer plot, and here this is really showing you every single patient. The only thing I would point out here is that 2 of the patients have already left the trial because their tumors shrunk enough that they were able to have a surgery with curative intent. So we were very excited about that as well. And this really tells you all the numbers in general, just more of a summary of that. And the demographics and baseline characteristics, I don't expect you to be able to read that from where you are in the audience. Bottom line is that we're not really seeing anything skewing the data at this point as far as baseline characteristics. And then also the safety data, what we're seeing right now is it's well tolerated. We're not really seeing an increase in neutropenia and other toxicities with the addition of Onvansertib to the chemotherapy. So what I've been talking to you about really is on the left side. It's called Cardiff 004. This is the trial that we're doing right now, which will be 90 patients, and it's really identifying the dose, which at the moment, looking at this data, we would tend to go toward the 30 mg dose, the higher dose. But also in our meeting, our Type C meeting with the FDA, we also, they agreed to really the 2 trials is really what the agreement was with the FDA. The first was the dose optimization, which is Cardiff 004, and then Cardiff 005 is the registrational trial in which it's a seamless one trial that will have both accelerated and full approval. Accelerated approval based on ORR, full approval with PFS with an OS, lack of detriment on overall survival. So how did we really get there? How did we get to this point in our journey here at Cardiff Oncology? And it really started out with a second-line trial where we were going after patients who had a KRAS mutation, and they had already progressed on first line, and they were coming into a second line. And this was a trial on the left side. It was second line. It was KRAS mutated, unresectable, same dosing schedule and looking at response rates. But one thing that we didn't know at the time when we started to do the trial was that we actually had 2 different kinds of patients coming into our second line trial. And what I mean by that is we had patients who, they all got chemotherapy and had progressed on that, but some of them had gotten Avastin, or what we call Bev, and some didn't. And that actually, we didn't know at the time, but that actually made a big difference. And what I mean by that is if you look at that on here, the left side, you can see that these patients here that were what we call Bev naive, they did not have bevacizumab or Bev in first line, they had a much greater response rate, 73%, versus those that were exposed, which had a 16%. Historically, a Bev-naive patient, we're expecting around a 25% response rate. So we had about a 3-fold increase in our response rate. So this was really something that we also noticed when you looked at PFS, it was also extended. So we went to almost doubling of our progression-free survival to about 15 months. And then we went and did more statistics on this and really showed with that and then the multivariate analysis that really only the Bev status, that is to say whether you were Bev naive or Bev exposed, made a difference as far as response. So then the question really came down to, well, what's going on? Is there something going on in a tumor that sees Bev for the first time and sees Onvansertib for the first time? Is there something going on that we did not know and it was not in the literature? So we had to actually go back to the bench and actually do some experiments. And the logical first experiment was this one where we said, well, let's take a KRAS mutated human tumors and grow it on a mouse, the hind leg of a mouse, basically a mouse model of a human tumor of the KRAS mutated CRC. And you can see here that we're looking at on the y-axis tumor growth, and so the combination of Onvansertib with Bev had a greater effect on tumor growth than either agent alone. So we thought, well, why don't we do a couple more? So we did a couple more models of KRAS mutated CRC, and we saw the same thing in the gold line down here on the bottom, a greater effect here. So on those last 2, we said to the CRO that was doing those experiments for us, we said, look, why don't you do a gross dissection and take a photograph of all the tumors and send that to us? Because we might be able to tell something even in the naked eye. And we did. They did do that. And what you can see here is that the control, of course, is a very vascular tumor. Bev and onvansertib alone as single agents, you saw smaller tumors and less vascular. But when you look down here, what we saw was not only a smaller tumor, but really a much more pale tumor. So in other words, it looked to us, even by the naked eye, that we were dealing with something where both drugs were working in the same pathway to shut down vascularization of the tumor. So that led us to a whole area of research that's actually quite well known. It's a hallmark of cancer. It's called hypoxia. Tumors, as we know, their growth outpaces the ability of vessels to innervate them to bring oxygen and nutrients. And so tumor cells in the middle of a tumor cell usually is a low oxygen, it's a hypoxia. Now, these tumor cells don't die because they adapt to this, and they express a transcriptional factor called HIF-1 alpha, or hypoxia-inducible factor 1 alpha, which then turns on a whole plethora of genetic program of other genes, one of them being VEGF. And we know that bevacizumab, we know how Bev works. It basically neutralizes the VEGF, which is, of course, the trophic factor that attracts blood vessels. But what we didn't know was that onvansertib actually shuts down the master switch that allows a tumor cell to adapt to hypoxia and shuts down the ability of a tumor to be able to adapt. Now, how did we know that? And by the way, how am I doing on time, Eric? 10 minutes. Okay, I'm going to not give you all the Western blot data here. I'm just going to keep moving. But I'll just point out here that what we saw here is we went back and did cell lines within colorectal. And what I will say is that here's a cell line here. It's a RAS mutated cell line. And normally when you have oxygen at 20%, that's our normal oxygen as we sit here in this room. But at 1%, that would be a hypoxic conditions. Now, we know this is a Western blot. This is looking at protein levels. And you can see here that it is induced. When you have onvansertib, it's no longer there. And that was really the essence of the finding. And I won't go through that data. This was all published in Journal of Clinical Oncology, JCO, which is the ASCO flagship. This was published back in October of last year. The actual article is free if you go online to JCO. And it really talks about not only the phase 1b/2 trial that I just talked to you about, the clinical, but importantly, the translational work that was associated with it, and really our discovery of this mechanism of action showing that we were able to inhibit the HIF-1 alpha pathway. And this is really a cartoon in that article that shows you really a Bev naive tumor versus a Bev exposed. And in the Bev exposed, the reason we believe that patients are not responding here is the data that we presented in this article was that tumors that are exposed to, previously exposed to Bev, as in the patient population that we had that didn't respond, they also have the biology of that tumor is radically changed, and there are gene networks that are turned on that are basically capable of giving resistance to both Bev and onvansertib. So we believe it's really the resistant mechanisms that are the reason why we're not seeing that activity. So I think, really where we are today is what I've talked to you about is that we will be having another readout with more mature data later in the first half of this year. And so that was really our next inflection point. As of December 31st, we had $91.7 million cash. We have runway into first quarter of 2027. And we burn about, right now, and this is a 6-month, is 20 million, so about 10 million a quarter. I think that really, I finished that's pretty much it, and I thought I could take any questions. Yes. Matt.
How many patients, in addition, you've shown 30 patients so far. How many can we expect the first half of this year?
It'll be at least 60 patients that will be, or more than that, in the next readout.
And then how is the enrollment going overall?
We announced already that we have basically stopped the screening for the trial. We expect full enrollment of the 90 patients by the end of this month, which is pretty close, or early next month. Any other burning questions for anybody? Well, I appreciate your time and enjoy the rest of your day. Thank you.